When in danger, it's natural to feel afraid. This fear triggers many split-second changes in the body to prepare to defend against the danger or to avoid it. This fight-or-flight response is a healthy reaction meant to protect a person from harm. But in post-traumatic stress disorder, this reaction is changed or damaged. It is by definition the consequences of experiencing extreme stressors referred to as traumas. In everyday conversations, people refer to a wide range of events as traumas, from a romantic breakup to horrific tragedies. The DSM-5 constrains traumas to events in which individuals are exposed to actual or threatened death, serious injury, or sexual violation. The person who develops PTSD either directly experience or witness the traumatic event, learn that the event happened to someone they are close to, or experience repeated or extreme exposure to the details of a traumatic event. PTSD was first brought to public attention in relation to war veterans, but it can result from a variety of traumatic incidents such as mugging, rape, torture, being kidnapped or held captive, child abuse, car accidents, train wrecks, plane crashes, bombings, or natural disasters such as fires, floods, tsunamis, earthquakes, hurricanes, and tornadoes. A diagnosis of PTSD requires the presence of 4 types of symptoms. The first involves repeated re-experiencing of the traumatic event. PTSD sufferers may experience intrusive images or thoughts, recurring nightmares, or flashbacks in which they relive the event. The second type of symptoms in PTSD involves persistent avoidance of situations, thoughts, or memories associated with the trauma. The third group of symptoms in PTSD involves negative changes in thought and mood associated with the event. And lastly, the fourth type of symptoms includes hypervigilance and chronic arousal. People with PTSD are always on guard for the traumatic event to recur. Studying parts of the brain involved in dealing with fear and stress also helps researchers to better understand possible causes of PTSD. One such brain structure is the amygdala, known for its role in emotion, learning, and memory. The amygdala appears to be active in fear acquisition or learning to fear an event, such as touching a hot stove, as well as in the early stages of fear extinction or learning not to fear. Storing extinction memories and dampening the original fear response appears to involve the prefrontal cortex area of the brain, involved in tasks such as decision-making, problem-solving, and judgment. In the United States, projected lifetime risk for PTSD using DSM-4 criteria at age 75 years is 8.7%. 12-month prevalence among U.S. adults is about 3.5%. Lower estimates are seen in Europe and most Asian, African, and Latin American countries, clustering around 0.5% to 1%. Women are more likely to develop PTSD than men, and there is some evidence that susceptibility to the disorder may run in families. Cognitive behavioral therapy has proven effective in the treatment of PTSD. The client identifies thoughts and situations that create anxiety, ranking them from most anxiety-provoking to least. The therapist takes the client through this hierarchy using relaxation techniques to quell the anxiety.